Clinical trials in medicine have long used placebos to benchmark whether new treatments are effective. If the group that gets treatment does better or worse than the group getting fake treatment, it's a simple way to know if that drug is the real deal, right? Well, new research says maybe not. The placebo, it seems, may have healing properties of its own. To find out more, we welcome in Boston, Massachusetts, Ted Kapchuk, professor of medicine, Harvard Medical School, and director of the program in placebo studies and the therapeutic encounter at Beth Israel Deaconess Medical Center. In Montreal, Quebec, Amir Raz, Canada Research Chair in the Cognitive Neuroscience of Attention at McGill University and co-editor of Placebo Talks, Modern Perspectives on Placebos in Society. And here in Toronto, Ofer Agid, clinical scientist and psychiatrist at CAMH, the Centre for Addiction and Mental Health, and associate professor in the Department of Psychiatry at the University of Toronto. And we are happy to welcome our guests in Points Beyond and here in our studio to this most fascinating discussion about something that, is a real revelation. Ted, let me start with you. How did you end up studying the placebo effect to begin with?
Well, I was originally trained as a herbalist and acupuncturist in China. I was recruited to Harvard Medical School to help do research in Asian medicine. And as part of my rehabilitation, I was trained that the key question is, are these therapies more or not better than placebo? And I'd ask quite often, I said, what is this placebo? And I was told, it's the effect of an inert substance. And I said, inert substances don't have effects. It's an oxymoron. And I said, you know what, I'm switching my career to the placebo effect. If someone at a great university can give such a bad definition, meaning that there's a vacuum of knowledge and information about this phenomena. So I switched to studying placebo effects.
And how many years ago was that?
About 20. 25.
So you've been at this for 20, 25 years.
Yep. Still don't know too much, but I'm trying hard.
Okay. Well, whatever you know, we're going to have our audience find out by the time we're done with you tonight. Amir, I take it you have...
a little more than the audience, so don't worry.
Okay, good. I'm glad to hear that. Amir, I gather you, once upon a time, did work as a magician. And
Absolutely.
Now, how does that inform what you're all about right now?
I think it informed it a great deal. I started out, being an amateur magician. I grew up to be a slightly more advanced magician, and I started getting into magic circles and so on. And pretty soon I realized that there's a lot of behavioral science behind it, a lot of social psychology and so on. And the road from performing and being a showman to being a scientist who studies human behavior and the power of expectations and manipulation and so on was very, very, a short road to take and a very informative one.
You didn't happen to bring a magic trick with you tonight that you could show us right now, did you?
I think that would be inappropriate.
Okay. The deck of cards will remain in the pocket. We'll do it another time. Mm-hmm. Ofer, I want to just put a quote to you that is from you in the CAMH Discovers magazine that CAMH puts out, and here we go. There is a disincentive, you say, for drug companies to invest in new compounds for psychotic conditions such as schizophrenia, which you study, because the placebo effect is so strong that the drugs don't get approved and money is lost. Can you give us an example of the placebo effect scuttling a potential new drug treatment?
Yeah. One of the problems that we see is that the placebo effect, and I will focus on schizophrenia studies, is getting stronger over the years for unknown reasons. I mean, we can speculate about the reasons. And recently, during the last years, many drug companies that put forward different compounds to investigate as antipsychotics, medications that we use for schizophrenia, failed to separate from placebo. The placebo was either stronger or the same effect. And these drug companies, it was the process of developing a new drug is, of course, extremely expensive, extremely long. And this is a huge disincentive for the pharmaceutical companies to think and develop new compounds.
As you have learned that the placebo effect may be, in some circumstances, just as good as the real thing, how do you react to that?
Yeah, that's, I must say, it's an interesting phenomena. And if we focus on schizophrenia, when we see A, strong placebo effect, and B, the placebo effect is getting stronger over the years, we have to sit down and think what's going on. And the short answer is that we don't know, but the longer answer is more complicated than that. I think that in the area of schizophrenia, it's at the end of the day a selection bias.
Selection bias meaning?
Meaning that we design our double-blind placebo-controlled studies a little bit differently during the last years. And a certain subtype of patients that might respond better to placebo will be recruited to these studies. And this may confuse the results. So if in the 60s, placebo studies were rarely, or they usually the compound beat, quote unquote, placebo, nowadays, because we have a different population, a different subset of patients recruit to these studies, we see different effects. And the question is, why do we recruit this subset of patients? How come this subset of patients enter our studies and ruin, again, quote unquote, our results?
Gotcha. Well, let me ask our director, Sheldon Osman, here to play a clip that will provoke the next part of our discussion. Jeffrey Mogul of the Pain Genetics Lab at McGill University has shown that for pain treatments and for those studies, the placebo effect is increasing in the United States. And here's the clip explaining one possible reason why. Sheldon.
Americans now know all about the placebo effect, and they didn't in the past. And it's possible that exposure in the media to the concept of the placebo effect being real has actually increased over time, and possibly to a greater extent in the US than elsewhere.
Amir, you're part of that conversation. Do you have any other explanations beyond that?
Yeah, I mean, I think that this is a very complex question. It's very multifaceted, and it's got a lot of, vectors playing here. There's no question that we have a lot more information available to us. I don't think that the public knows everything about the placebo effect. We certainly don't, and I don't think that the public does either. But there's certainly a lot more information floating around. In places like the United States and New Zealand, from all places, we have direct-to-consumer marketing of drugs. People feel that they know more about medicine than they did before. The fact that information is flowing also brings in all kinds of irresponsible information. In general, there's a sense that the era that we live in today contains a lot more expectations than it did before in certain domains. And as a result of that, I would expect it to directly influence, shape, and mold our placebo effects, our placebo responses. That sounds like a natural thing to me.
What kinds of explanations, or expectations, excuse me?
So expectations can be something like, this particular drug helped my neighbor, therefore, it could help me because I'm very similar to my neighbor. An expectation could also be a little bit more subtle in the sense that my son seems to be exactly like me, and I remember that when I got up in the morning and I drank this purple liquid, it really helped me with tests, therefore I recommend it to my son, and so on and so forth. This would be sort of one level, but at the community level, at the society level, I think that we are certainly following particular trends. It could be, trends for antidepressants. In early days of the antidepressants, people were seriously considering, at least some people, to add antidepressants into the drinking water because it was so successful and everybody was so enamored of it. Today, the situation is slightly different. So I think that there's a lot that is happening in a society and in the mindset, in the climate of knowledge that actually influences what people are thinking, and as a result, their culture of healing.
Ofer, you wanted to add.
Yeah, I would like to echo what Amir said and to add that in our studies, we found that one of the predictors for placebo is, for example, where did the patients came from? University hospitals versus community hospitals. So this might hint us how come suddenly we see increased inflated placebo response. Of course, there are many other factors that happened over time. Monetary incentive to the doctors and patients over time. When you look at the 60s versus the 80s versus the 2000s. So there are many factors there that probably impact the placebo response.
Why would a university hospital versus a community hospital make a difference?
It's a very good question.
And people don't know?
I don't know the answer.
Okay.
I can, speculate, maybe boundaries of the diagnosis, maybe different subset of patients.
Well, I think there's some very easy explanations that, that even before we get into these nuances, nuanced things, if I run a study, even a simple study, and I do it at Harvard Medical School, that has a particular name and a particular cachet, even within non-academic circles, and I do it in a no-name school, in a no-name place, I think that the responses or the results of the experiment are likely to be different just based on the theatrics, based on the reputation, based on the, I would say, psychosocial factors that surround it, envelop this particular study.
Interesting. Ted, let me put this quote to you. This is from National Geographic, and it's a quote about a new gene therapy treatment for Parkinson's developed by, and I'm probably going to get the pronunciation wrong here, is it Serogene? Is that how it's pronounced?
That's fine. Yeah.
Okay, close enough.
Sounds good to me.
Sounds good. All right, here we go. Serogene's experimental treatment was to cut 2 holes, one in each hemisphere of the brain, through a patient's skull and inject the drug directly into the target regions. In April 2013, Serogene announced the results of the trial. Nerturin, I guess that's drug, had failed. Patients who had been treated with the drug did not improve any more significantly than those in a control group who had received a placebo treatment, a sham surgery in which a doctor drilled divots into a patient's skull so that it would feel as if there had been an operation. And I wonder, Ted, if you can help us with some of the ethical issues surrounding a study that goes so far as to include sham surgery.
Well, first of all, every patient had to sign an informed consent. An ethics committee looked at that informed consent and made sure that it was honest, transparent, and clear, that it accurately described the risks and benefits. I have to say that I probably would never have gone into that surgery. I wouldn't let my mother in it. But that's because the risk of surgery is high. But apparently the investigators and the ethics committee felt it was an ethical thing. As long as people agree to what's going to happen, there's usually not an ethical barrier. I think that people would say, people can argue and say the risks are too great or the risks are not that great. But in fact, as long as you have informed consent, transparency, respect for people, people can enter an experiment. There's no ethical question in my mind about that surgery.
Offer, would you follow up and tell us about one of the patients who participated, a guy named Mike Politich?
Very interesting story. This guy had severe Parkinson. He was actually handicapped because of this illness. And after the sham surgery, the placebo surgery, he got up and could walk. One can argue that the reason this particular compound did not beat placebo is because of these specific patients that ruined the statistics because of this dramatic placebo response. I looked at the data of this study and similar studies, and it's looked like in Parkinson, and I'm not sure about other severe illnesses, in Parkinson there is usually a dramatic placebo response. So in this particular study, for example, a group of patients, around 23 patients that took the active medication versus 23 patients that only holes were drilled into the skull, but no real treatment was given to them, you could not separate their response for 6 months. Dramatic response to placebo. Now, maybe it's because Parkinson involved dopamine, maybe because dopamine is related to the placebo effect. I don't think that we know, but dramatic response to placebo arm.
And dopamine naturally occurs in the brain, right?
Yes. And in Parkinson, there is less dopamine.
There's less dopamine.
Yeah.
Amir, any view on this sham surgery story we're talking about?
Yeah, I mean, it's important to understand that although it sounds like this is, a new revelation and so on, for people in the field, this is actually something that has been known for a really long time. Sham surgery does sound a little bit weird to people who are not used to it, but sometimes sham surgery is necessary in order to evaluate or try to get a good estimate of a particular procedure. Sham surgeries have been around for a really long time, and we see sometimes dramatic results with sham surgery. Certainly sham surgery to the brain is nothing to sneeze at, but I want to sort of point out that what was used to be, or what we considered to be ethical years ago, is not ethical today, and probably what we consider ethical today is not going to be ethical in the future, and vice versa. Ethics is a changing, breathing kind of thing, and that too depends on trends and things of that nature. One thing is for certain, though, we have particular conditions, medical conditions, diseases, illnesses, syndromes that are more susceptible to placebo effects, and particularly maybe susceptible to sham surgery of particular kinds. Parkinson is one of them, and we've known that for a really long time, including some really interesting research that came out of Canada a few years back and got some very nice coverage about the idea that sometimes when people expect to get a dopaminergic drug, a drug that increases dopamine in the brain, even if they get a placebo, they actually get much better. And the interesting thing about Parkinson's is that you can actually see it in their motor output, in their ability to move around and so on. So it's a very dramatic, striking kind of visual to see people who get nothing, so to speak, although it's not nothing, it's a placebo, which is a real thing. And as a result of this nothing, they actually get so much better. So it's a very dramatic, vivid thing to see.
Well, let's do another example here. Ted, I'm going to ask our director, Sheldon, once again to bring up a graphic reflecting some of the results you got from your Maxalt study. There's the graphic there. And we see quite significant reductions in pain on 3 different kinds of levels. One placebo, one labeled a placebo, and one labeled the real deal. Take us through it.
The first bar is the placebo was labeled Maxalt.
Yes.
What we did there, this is in 459 acute episodes of migraine attacks. It's a pretty intense number of people. What we did at one point in the study is give people placebo pills and told them on the label that it was Maxalt. We were giving them a positive anticipation of benefit. In that situation, about 30%, there was a 30% on average reduction in their migraine pain in 2 hours. The next time we treated people, we gave them, or in random order, we gave them the drug, but we labeled the envelope placebo.
Right, that's the middle
And
bar.
basically what we tried to do there is take out the anticipation, positive expectation, anxiety reduction, whatever the mechanisms are, and just have the pure pharmacology, because we're giving them the drug, but we're not telling them it's a drug. And the improvement on average was 38% reduction in pain in 2 hours. That's not statistically different. Then when we gave them at a different time, a different headache, the drug, Maxalt, and the label on the envelope said Maxalt, the pain reduction went up to 62%. What happened there is kind of a lot of amazing things happened. We changed one word, the word Maxalt and placebo, not the word popcorn, but one word. The drug was 50% more effective. The other thing is that the placebo effect was at least 50% of what the drug effect was. We think that there are many drugs where the effect of the drug, we have a lot of evidence for that, is at least 50% the efficacy of the drug, meaning the drug does something, but it actually needs to build on a placebo effect. That's kind of amazing. It tells us that placebo effects are not necessarily about sugar pills and saline injections. They're part of every drug, or many, many drugs, that we give people every single day in clinical care.
Amir, can I get you to follow up on that?
Is that clear?
Yeah, absolutely. But I'm going to get Amir to follow up on this issue. What I found fascinating about that was that even when you told people they were taking a placebo, the pain reduction was still significant as well. How does that make sense?
Yeah.
Well, the whole notion of open-label placebo, or the idea of giving people a drug that they know is not a drug but is a placebo, is a very interesting one, because it appeals to some kind of a metacognitive level. When you are taking something that you know doesn't have the ingredients that are the chemical ingredients that are supposed to help you, but still there's something about it that is supposed to help you, and you can dress it up with all kinds of theatrics and with all kinds of accoutrements that would make it helpful. And the fact of the matter is that it is helpful for some people, and sometimes it is as helpful and sometimes more helpful than some of the conventional medications that we have. And that is an interesting prospect that often we don't address enough. For all kinds of reasons, for commercial pressures, for reasons that have to do with ethics and so on. But the fact of the matter is that we are today, scientifically speaking, at the cusp, or on the verge of beginning to certainly discuss and sort of pave the road to a more scientific understanding of placebos, not just from a molecular, cellular, or kind of system neuroscience perspective of what's happening in the brain or in the physiology of the human being when you get a placebo, but also from a humanistic standpoint, things that are related to shamanism, to appealing to a higher authority, to things that have to do with paternalistic medicine, and things of that nature. And I think it brings out a very important discussion that talks about placebos in general, not just in the context of pain, which is a very important context in medicine, but in the context of disease and healing and the theatrics of healing and the theatrics and the showmanship of curing. And these are very important parameters that are often ignored in medical school and in clinical circles.
Ted, I want to do one more set of bar graphs with you here, and this is the one that's in the case of a clearly labeled placebo, the percentage of respondents with adequate relief, we've got 35% with no treatment and 60% with open placebo. Take us through the neurobiology behind this result, if you would.
Well, there's no neurological, biological component of this, so some of it's speculative. But on the behavioral level, what happened is that people who took a placebo knew they were a placebo, that it was a placebo, had to sign on the informed consent. I know I may receive a placebo and will be told I'm receiving a placebo in the study. Took that placebo. They had 50% more reduction than the people who took nothing or didn't change their what they were doing in their lives about this was an irritable bowel study. And what we assume is, I think the word, I'm going to say, I'm going to use Amir's word, theatrical, that the participation in a randomized controlled trial, lots of questions, lots of examinations, a lot of inquiries, careful attention, being touched during the exam, being given emotional support, really developing rapport with several people, that it was like the real thing. The only thing that was not real was the pill. And in fact, what we assume is that the same things happen in the brain, the release of neurotransmitters like dopamine and endorphins, cannabinoids, happens when you give a placebo double blind and when you give it open label. As long as the theater is good, meaning as long as there's real supportive care, sometimes it seems, and we've done a couple other experiments in open label placebo and have more in the pipeline, sometimes even if you know a placebo is an inert substance, everything that surrounds that placebo is still there. And the brain will color in that, will modify the symptoms by releasing its internal pharmacy of neurotransmitters that change, that amplify or dampen symptoms. So that's what I think is going on.
Fascinating. Okay, Offer, I want to ask you another one of those ethical questions that we were considering earlier, and that is, have you ever, in your work in psychiatry, prescribed placebos outside of a drug trial?
Never. God, no. God, definitely not. And, with your permission, I would like to be a little bit of a devil's advocate here. There is this romantic concept about the placebo effect and how amazing is the placebo effect. The body can heal itself, and we might not need medication at all because we have the placebo effect. I think that it's a very important timing to put a word of caution. And for example, let me bring one of our studies, and I'm dealing with schizophrenia, severe complex mental illness. We reanalyzed, and we recently published it, the longest placebo study, double-blind control study for patients with schizophrenia. It was 1 year study. Can you imagine? Severe complex mental illness, patients with schizophrenia were treated 1 year with placebo. And what we found is as follows. There was some kind of dramatic response or response to placebo during the short time after the beginning of the study. But later on, all the patients relapsed, or the majority, the vast majority of the patients relapsed. And I think that we have to be very cautious when we're talking about the placebo and the romantic concept of placebo. We have to be very cautious. I guess that placebo is wonderful for mild depression, mild mental illness. I'm not sure what's the long-term effect of placebo in diabetes, complex mental illness, severe mental illness, cancer, and so on and so forth. So we have to be very cautious here. The reason I told you that I never thought about prescribing placebo is because when we are talking about severe complex mental illness, so maybe hypothetically a subset of patients will respond temporarily to placebo, but we are dealing with chronic illnesses. On the long run, probably no one or only a very small subset of patients will respond to placebo.
So you are not yet prepared to throw out your prescription notepad
Definitely
yet.
not, and it's very important to remember that we have to differentiate here severe, serious mental illness versus non-severe, non-complex mental illness.
Understood.
May I jump in and
Please.
just follow Ofer? I think caution is more than important, it's critical. But I want to say two things. It's very clear to me, I don't think we need more evidence, that you can't shrink tumors with simulation of therapy. You can't lower cholesterol, you're not going to lower blood sugar. There's only things that are modulated in the brain are going to get affected by placebo effects. That's one thing I want to say. The second thing is, if you look at, and you're right, we have to be very careful and selective, but if you look, for example, at the Parkinson's surgeries, the outcomes are 6 months to a year. You still have a placebo effect. It really depends on the condition. If you look at the vertoplasty surgery, where they compared injecting cement into the spine for spinal microfractures in the spine, that study followed patients for 2 years, and they had the real surgery and the fake surgery. Both of them responded equally and very dramatically positive. So it depends on the condition. Sometimes I agree with you. We can take an inflated view of placebo, but I just don't want to say, so I hope I'm being supportive of your question.
Understood. Yes, indeed. Amir, let me get you in here at this point, and I want to ask you about a study you did back in 2011 and what you found out about doctors who were prescribing placebos. Tell us about that.
Yeah, well, I think that what I'm about to talk about relates directly to the caveat that we were talking about not trying not to romanticize placebos too much. There's no question that placebos are effective and sometimes very effective, but there's also no question that there are certain situations when placebos are downright inappropriate and should not even be attempted. I would never encourage anyone to provide placebos to treat malaria and so on. However, part of the study that you're asking me to describe gets at the same question. It turns out that many physicians, particularly savvy physicians, are so well aware of the qualities and of the potency of placebo effects that they actually find ways to use placebos without risking their license being disbarred, without risking their reputation being tarnished. And there are many ways that people do this, and they're different in the United States than in Canada, just because these are different communities in terms of litigiousness and things like that. But by and large, there's a way that particularly seasoned physicians use placebos, and that's by giving their patients either subtherapeutic doses. We're not talking about homeopathic doses. We're talking about subtherapeutic doses of particular drugs, be it psychiatric drugs or dermatological drugs. It doesn't really matter at the moment. But they basically give drugs that are real drugs, but at a dose that is below the known clinical effect, in such a way that they still give a drug as opposed to a placebo, but they know fully well that this particular drug is not likely to have an effect other than the placebo effect. Now, this particular kind of thinking happens to be something that comes out when you speak to, at least when I spoke to physicians confidentially, and when I gave them the latitude to report, at least to some degree and in some sample, to their practices. Of course, this is more prevalent in some specialties than others. And for example, I'll just give a quick example. In pediatrics, for example, I think most pediatricians would tell you that other than treating the child that comes to the clinic, it's also important to treat the parents, because often the anxiety that the parents have would rub off on the child and so on. So these are clinical observations that astute physicians realize, recognize, they know how to deal with. And we're not talking about giving a placebo just in order to placate the insistent patient. This is not the case. We're talking about using placebos clinically in a way that would not risk or would not violate some kind of bad form behavior on part of a professional, in this particular case, a physician.
In which case, Ted, tell us what, in your view, the placebo effect tells us about what patients truly need from their doctors.
Well, I think that, look, we know for sure a sugar pill doesn't do anything. It's no biology there. What does something around when a person receives a placebo is everything that surrounds the pill. Attention, empathy, compassion, touch, an exchange of emotional support, an explanation of things. What I think the placebo is marking is not that there's a magic in nothing, but it's marking that everything that surrounds either a placebo pill or a drug or surgery, everything that surrounds that makes a significant contribution to healthcare. And it's not enough for healthcare providers to use the tricks in their black bags, the drugs, procedures, or alternate medicine, what have you. Providers, clinicians need to pay attention to the interaction, the patient-doctor relationship, and everything that surrounds their care, because that sometimes, as I showed in that migraine experiment, is 50% of what the patients get from an encounter.
Offer that checklist of things that was just mentioned by Ted. Is there enough of that in the healthcare system in Ontario today?
Definitely not. And I think we should definitely pay attention or more attention to it, because as healthcare professionals, we are giving the patients, of course, the psychopharmacological, psychosocial. There might be another component that we might at times maybe ignore, and this is the placebo effect. We can call it other names, if you may, but I think it's very important, this kind of theater around the intervention, and of course, empathy and so on and so forth. I think we do a lot of it, of course, especially in the CAM-H, of course. However, we can do more. We can definitely do more. And what I said before regarding the complex mental illness that probably will not respond to placebo, I would like to rephrase it. I guess that a placebo add-on will be very important. So we are giving our psychopharmacological intervention, but a placebo add-on would definitely will be beneficial for the patients.
With just a few minutes to go here, Amir, I want to pull a quote from an article you did called Placebo Science in Medical Education, and here's the quote. Placebo science bridges the gap between the art of healing and the science of medicine. A prominent medical historian argues that physicians are walking placebos. In which case, how does medical training need to change as a result of what we've learned about the placebo effect, in your view?
Well, I think that medical training is a very important avenue to educating the physicians of the future and the clinicians of the future on how to use placebos judiciously and also ethically. The word placebo is confusing to a lot of physicians today. Some people treat it as a nothing, as a zero, and other people treat it as some kind of a comparator or some kind of a benchmark to compare against. I think that, in medical school, there's very little discussion of placebos. I think that the placebo knowledge that a radiologist or a pathologist would need is very different from the placebo knowledge that a dermatologist or a surgeon would need, certainly a psychiatrist. And I think that these are medical facts or all kinds of educational information that is extremely important in order to enhance, increase, and improve the health of patients and in order to create medicine that is more effective.
Ted, in our last minute, let's finish up on this. What impact do you think the cost of the pill would have on the placebo effect?
There are one or two studies that say that a more expensive pill is more effective. Those studies done in healthy normals. I think that healthy normal people who had no illness, I think that we don't really know. I think that placebos are usually much cheaper than drugs. I think the issue is, one, is there ways of ethically using placebos? That's a big issue, and consumers and the public need to be brought into that discussion besides medical people. And two is that more important than the pill is attention to what surrounds the pill is a vital component of what patients derive when they go to a healthcare encounter, and it's actually a big part of what holds our system up. The so-called placebo effect is about the emotional support and mutual trust that's created when people seek healers.
Well, I have to say, that was an utterly fascinating last 35 minutes of television in this guy's life. Ofer Agid from the University of Toronto and CAMH, thank you so much for being here.
Thank you.
And to our two guests on the line, Ted Kapchuk from Harvard Medical School and Amir Raz from McGill University, my gratitude for your participation on this evening's program as well. Thanks so much, everybody.
Thank you.
Thanks so much.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.